I would like to spend a few minutes discussing the management of ventral incisional abdominal hernias. And this is something that we see relatively commonly. A hernia basically is a defect in the muscular wall of your abdomen where the muscle separates and the contents of your abdomen actually push out through it and can be felt as a mass almost underneath the skin, or a bulging of the skin. There's many types of hernias. You have your inguinal hernia that occurs in the groins. Inguinal hernia occurs in anywhere between 10 to 15% of the population. The reason people get those is because the spermatic cord that suspends the testicle and the scrotum comes through the abdominal wall at that location, and so it's a naturally weak area. We can also see hernias in where the belly button is, what we call the umbilicus, an umbilical hernia, and again, about 15% of people will get those in their life. This is another naturally weak area. It's in the center of the abdomen where the muscles all come together, and also that's where your umbilical cord was when you were a fetus inside your mother, and so that's another naturally weak area. The type of hernia that I want to discuss management of with you is what's called an incisional hernia, and as you can imagine, an incisional hernia occurs where the person has had previous surgery, typically in the midline, but it can occur on the sides, what we call a flank hernia, or a subcostal hernia here under the ribs, or in other locations. So generally it occurs in the midline of the abdomen, and the patients usually present with bulging at the site of their previous surgery. They may not even realize they have a hernia. Sometimes they just notice that there's a bulging in that area. And often the primary care doctor may just pick up on that when they examine the patient. Sometimes a incisional hernia can be asymptomatic other than the bulging, but most commonly it causes symptoms of pain with straining or lifting and things like that. In a more severe case, a hernia can develop what's called incarceration. That's where part of the intestine or other contents of the abdomen come out through the hernia and get stuck in the wall of the hernia so that they can't go back inside the abdomen. And when you have an incarcerated hernia, that's more of a problem for the patient. They can get things like a bowel obstruction if the intestine twists in there, or if the blood supply of the intestine or contents of the hernia gets squeezed off. They can get gangrene of the intestine, and that can make them critically ill. It can even cause a perforation of the intestine. So anytime the patient's having symptoms, or especially an incarcerated hernia, that's something that we need to see in a timely fashion, or maybe sometimes even on an emergency basis. Even someone who's having minimal symptoms from an incisional hernia often is a good candidate for repair, because especially if they're young or fit and will be able to tolerate surgery well, because if you don't fix the hernia, if you don't repair it, it's really never going to go away on its own, and as time goes by it will grow larger and you can get problems from them down the road. So generally, as long as the patient is an acceptable candidate for surgery, we would recommend repair. As far as the types of repair, how we do the surgery, there's many different techniques and many controversies about the management of incisional hernia repair. I'll just tell you what I generally recommend, and this is an operation that's called incisional hernia repair with preperitoneal mesh placement, or what we call a Reeves Stopa repair. And so for this operation, it is an operation where we use mesh, and mesh is it's usually a sheet of material that's made out of various different materials. The one that we use is made out of polypropylene, and polypropylene is the same thing that's in fishing line. It's like a form of plastic, and the polypropylene mesh has been on the market for many, many years, more than 50 years. It's been shown to be durable and very safe. Not the kind of mesh that you might have seen on TV where people that are wrapping around the intestine or the body rejects it and people are suing everybody. This is a different kind of mesh. This is just straightforward polypropylene mesh, tried and true, that's been used for many, many years. And typically the way I would perform the operation would be to do the surgery under general anesthesia, so the patient is asleep, and we make an incision around the previous scar, often trying to remove some of that excess skin. Especially for large hernias, there can be a lot of stretching where the skin is, and so if you just repair the hernia and leave the skin the way it is, you'll have a hernia that's repaired, but there will be a lot of bulging in the skin and redundant skin that's just not very cosmetically appealing. So usually what we will do, especially if it's a large hernia, is excise some of that redundant skin so that when we close it, it has an appealing cosmetic appearance, let's just say. So once we go through the skin and do that part of the operation, what we do actually is we divide the abdominal wall, the muscle, into a back layer and into a front layer. We take all the scar tissue down, make sure there's no issues with the intestine or anything like that. And then what we'll do is we'll sew that back layer of tissue together. And then on top of that, we place the mesh. And then we sew the front layer of tissue together so it's in the form of almost like a sandwich. Your own tissue is on the outside of the sandwich and it's reinforced with mesh. This operation is a little more time consuming than other operations and requires some experience learning how to do the operation and getting the best results. But it really offers a lot of benefit for the patient because the recurrence rate, the chance of the hernia coming back, is very, very low, and the risk of running into problems related to the mesh is low, because instead of taking that mesh and putting it inside the abdomen where it might be exposed to the intestine, the mesh is actually within the abdominal wall. Also, there are some operations where you might take the mesh and put it outside the abdomen, like on top of the repair, but in my opinion, those operations are a little bit suboptimal as well, because it's kind of like repairing a hole in a bike tire. I don't know if you've ever done that, but if you take a patch and you put it on a tire, usually you put it on the inside where it will push against it and reinforce the repair. But if you put that patch on the outside, it's not going to contribute to the strength as much, and in fact, you can still get a hernia underneath the mesh. So with this operation, the mesh actually goes inside the abdominal wall, where it will contribute as much as possible to the strength of the repair, but also not inside the abdomen where it can cause complications related to the mesh in the small intestine. In our experience with this operation, it generally takes about 90 minutes to do the procedure. Often the patient will be admitted to the hospital for one night. It is not uncommon for us to place drains under the skin so that fluid can collect. Fluid can be drained and it does not collect inside the patient, what we call a seroma, and those are generally removed in the office a week after the surgery. The recovery is anywhere between 4 to 6 weeks, but we encourage the patient to do things like to walk and be active afterwards. Generally just tell them no heavy lifting more than 5 or 10 pounds for 4 weeks after the surgery, and no strenuous exercise. In terms of the actual results of the surgery, in our hands, this operation has a 3.5% recurrence rate, which compares favorably to all other types of procedures. Very, very low recurrence rate, very low chance for further surgery in the future. In terms of complications, the main one we would be most worried about would be some sort of issue with the intestine, and That actually is very, very rare with this types of surgery. In the hundreds of operations like this that I've done, I can't remember ever having to take someone back to the operating room because they had a hole or a problem with their small intestine. So that's a theoretical complication, but very, very rare. One thing we do see is wound complications, and generally that would include fluid underneath the skin that gets infected, or even what we call hematomas, where there's some bleeding in the area because of the extensive dissection that we do. And those things most often can be managed with either local small procedures or drains in radiology. It would be unusual to have an operation for one of those things, but occasionally that does happen. Once the person is healed up from the surgery, generally they don't have any long-term effects. Once they're healed up, there's no limitations on their activity, and generally can go on to live a normal life and do whatever